I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. Welcome back to the Pop Pod. This is episode 2 in our ADHD series. Last episode, we talked about what ADHD actually is and why it's more than simply being distracted or hyperactive. By the end of this episode, you should have a better understanding of why ADHD medication is not chosen based on how severe someone's ADHD is, how to describe the main factors clinicians consider when selecting a medication, why two people with the same diagnosis may receive completely different treatments, why choosing ADHD medication is a process of shared decision-making and careful review rather than simply picking the strongest medicine. This is part of an 8-part series on ADHD medications. Each episode builds on the last, so while you can listen to them individually, you'll get most out of the series by following it from start to finish. And then, by the end, you'll have listened to around 2 hours of education. And if you're using this podcast as part of your continuing professional development, I'll also finish each episode with a few reflective questions to help consolidate your learning and provide ideas for your CPD record. This is episode 2, and we're answering some common questions I receive online. Why does one person get prescribed Ritalin and another Vyvanse? Someone else is on dexamphetamine, and another person takes a completely different medication altogether. Does that mean one person's ADHD is worse? Does Vyvanse mean more severe ADHD? Is Ritalin the starter medication? Or is one medicine simply better than another? And the short answer is no. Choosing an ADHD medication is much more like tailoring a suit than handing out uniforms. Let's talk about why. One of the biggest myths I see online is this idea that medications exist on some sort of ladder. People imagine something like this. You start on Ritalin. If your ADHD gets worse, you graduate to dexamphetamine. Then eventually you'll end up on Vyvanse. And if your ADHD is really mild, then your doctor will only prescribe a non-stimulant. And that simply isn't how prescribing works. These medications aren't ranked from weakest to strongest. They're different tools. Think of them like running shoes. A marathon runner, a sprinter, and someone hiking up a mountain in the snow all need shoes, but not the same shoes. The best shoe depends on the person wearing it. The question isn't, what is the strongest medication? The question is, which medication is most likely to help this particular person? First, confirming the diagnosis. Choosing a medication actually starts before the prescription pad comes out. A clinician is making sure the diagnosis itself makes sense. Could something else explain the symptoms? Sleep deprivation, anxiety, depression, trauma, substance use, learning disorders, thyroid disease, iron deficiency? Or is ADHD genuinely part of the picture? Sometimes more than one thing is happening at once. There isn't one type of ADHD. Even when two people both have ADHD, they have different lives. One person struggles to sit still. Another can't organise their day. Someone else mainly experiences emotional dysregulation. Others lose things constantly. Some struggle at school. Others don't realise they have ADHD until adulthood because they managed academically but burnt enormous mental energy doing so. The diagnosis might be the same, but the person isn't. That's why medication choice starts with understanding the individual. What clinicians think about. This is the heart of the episode. Age, children, teenagers, university students, parents, shift workers, older adults, all have different daily demands, and medication needs to fit around life. Also, what symptoms are causing the most impairment? Is morning routine chaos the biggest issue? Is school concentration the problem? Is it driving or university lectures? Is it evening parenting or emotional regulation? Medication timing should be chosen around when someone needs symptom control the most. How long does the medication need to last? This is one of the biggest decisions. Some people only need coverage during school hours. Others need it throughout the entire workday. Some need support in the evening because that's when the family life begins. Different formulations release medicine differently. That's why someone may receive immediate release tablets, long-acting capsules, long-acting tablets. Sometimes people even use a combination. Is there any previous response? If someone has previously taken methylphenidate, how did it work? Did it help? Did it wear off too quickly? Cause headaches? Upset the stomach? Cause anxiety? Not help at all. Previous experience guides what happens next. And side effects. No medication is a good fit if the side effects make life miserable. Clinicians think carefully about things like appetite, sleep, weight, mood, anxiety, blood pressure, heart rate, headaches, stomach upset. Every person tolerates medicines differently. And coexisting conditions. This is a really important one. Many people with ADHD also live with comorbidities: anxiety, depression, autism, tic disorders, sleep disorders, learning disorders, or physical health conditions, and these influence which medication may be more suitable. Also, lifestyle. People underestimate how important this is. Can the person reliably remember to take a lunchtime dose? Do they travel? Work shifts? Do they play elite sport? Drive professionally? Need medication to wear off before bedtime? Medication has to complement real life, not the other way around. Other medicines. Clinicians also need to consider interactions with the person's other medicines. And this is an area where pharmacists are particularly valuable because we are often able to build a comprehensive medication history, not only prescription medicines, but also over-the-counter products, vitamins, herbal remedies, and wellness supplements. And it's worth remembering, if something has the ability to produce an effect, it also has the potential to cause a side effect or an interaction. That applies to supplements and products described as natural too. Pharmacists therefore play an important role in identifying potential interactions, contraindications, and duplication across both prescription and non-prescription treatments. Shared decision-making. Prescribing isn't and shouldn't be a one-way conversation. It's a shared decision. The clinician brings the evidence, the patient brings their experience, their priorities, concerns, lifestyle. Some people are worried about appetite, others worry about cost, others don't want medication lasting into the evening, others do. These conversations matter because the best medication isn't simply the one that works the best in clinical trials. It's the one that works the best for that particular person. And sometimes it's trial and adjustment. Medicine isn't always the perfect fit on day one. Sometimes the first medication works beautifully, and other times the dose needs adjusting or another formulation fits better, or an entirely different medication works better. And that's not failure on behalf of the clinician or the patient. It's part of individualising treatment. Just like people respond differently to blood pressure medication or antidepressants or pain relief, people respond differently to ADHD medication. So, if two people have ADHD and one is prescribed Vyvanse whilst the other is prescribed Ritalin or Intuniv, it doesn't automatically mean one person's ADHD is worse. It doesn't mean anyone's medication is weaker, and it doesn't mean someone made the wrong decision. It simply means your clinician looked at two different people with two different lives and tried to choose the medicine most likely to help each of them. Consider these questions for your own practice. Think about the last patient with ADHD whose medication you discussed. Which factors beyond the diagnosis itself influenced the choice of medication or formulation? Have you ever heard a patient say something like, "My friend is on Vyvanse, so mine must not be strong enough," or "Why wasn't I given the same medication?" How might you explain the principles of individualised prescribing in a way that is clear and reassuring? Is there anything in your current counselling about ADHD medicines that you could improve? For example, do you routinely discuss expected duration of effect, common side effects, or the fact that finding the right medication sometimes involves adjustment over time? Pharmacists are often the only clinicians with a complete view of a patient's medicines. How would you incorporate a patient's prescription medicines, over-the-counter products, and complementary or wellness supplements into your assessment when discussing ADHD medication? In episode 3, we're going to start unpacking the medications themselves, and we'll begin with methylphenidate, what it actually does in the brain, how it works, and why formulations like Ritalin, Ritalin LA, and Concerta can all have the same active ingredient while behaving quite differently. I'll see you next time on the Pop Pod. Bye-bye.